Beta blockers in sepsis. Paulo Mergulhão, ICU Diretor, Hospital Luciadas Porto, University of Porto, School of Medicine Infection and Sepsis Group, Portuguese Society of Intensive Care.
What I propose to you is kind of a theoretical case. Our septic shock patient may be considered that his heart rate remains elevated despite your initial resuscitation. You've heard about the Morelli Trial, okay? The Morelli Trial included patients with persistent tachycardia despite fluid resuscitation. We've heard a lot about this, let's just skip it. It's effective in reducing heart rate without appearing to significantly compromise hemodynamics, but some odd data. Mainly, the huge amount of fluids patients were given, huge, absolutely huge amounts of fluids, and of course, you've heard about this, the mortality in the control room, in the control group, and even in the intervention group was unacceptably high. So this makes the study findings a bit different, a bit difficult to interpret. We've been trying to improve and to get more data on this, and very recently, just a few weeks ago, the LANDISEP trial was published in ICM. It's the largest trial of beta blockers in septic shock. And they used grossly the same inclusion and exclusion criteria that Andrea Morelli used, okay? I underlined the first of these exclusion criteria, any form of compensatory tachycardia. And I underlined it because this was left to the investigator's discretion. It's not very well defined in the paper, okay? And I think this is relevant when you look at the inclusion of patients. You screen more than 2,000 patients to include 200, meaning that we excluded from these patients more than 90% of the patients that were randomized. To me, this suggests that people are thinking about the issue of beta blockade in sepsis really, really very carefully. And there are still a lot of doubts that we need to understand better. Anyway, the main results were similar to Morelli's study, very effective in reducing heart rate, no effect at all, measurable effect on blood pressure, but unlike Morelli's study, there's a trend towards higher norepinephrine requirements in the LANDISEP group, okay? This is not significant as a cumulative dose at 24 hours, but you can see that at some time points, the confidence intervals are different. So there may be something here. And the mortality in both groups was what you would expect in a septic shock study. Not really different, although ICU mortality is not, how shall I put it, is disheartening. It's not the values we would like to see. But from a statistical point of view, mortality, both ICU and 28-day mortality was the same. So this brings me to my last case, and something that I want to show you as a note of caution when we're thinking about heart rate control in shock patients. And this was not a shock patient at the onset. This is a 60-year-old male coming into the ICU late September. No prior medical history other than some probable alcohol abuse. And he comes into the emergency department with acute atrial fibrillation and a fast ventricular response around 150. Tachymyopathy was suspected, but the patient was showing no symptoms of shock, no symptoms of acute decompensated heart failure. The guys in the emergency department tried a bit of, they gave it enoxaparin, of course, and they tried a bit of beta blocker with no impact. And so they started him on amiodarone and referred him to the ICU. Okay. Patient comes into the ICU, and within the first hour, heart rate drops to 70, and the patient collapses. He becomes unconscious, lactate shoots up to very high levels, and blood pressure was extremely low. amiodarone infusion was stopped immediately. He was given Atropine, started on noradrenaline, and transthoracic echo showed severely depressed left ventricular function, and so he was started on dobutamine. But what we saw is that after reverting the bradycardia, which was what this patient physiologically had, when he went back to a higher heart rhythm, the blood pressure quickly improved, the neurological status of the patient normalized, and actually by this time we were already giving him nitrates to get the blood pressure down. So why did I bring this case here? Because I think we still need to learn a lot before considering the right place for beta blockers in septic shock. And actually this is a matter of discussion and active investigation. Morelli is trying to find ways to analyze the peripheral arterial curve to maybe identify patients where the tachycardia is not compensatory, where there is the kind of ventricular-arterial uncoupling that might suggest to us that the tachycardia is inappropriate and where some benefit from beta blockers might be expected. For now, really be careful with the use of beta blockers in sepsis, as Bruno Levy suggested a couple of years ago. Make sure the patients are adequately filled, make sure that left ventricular function is not severely depressed, and don't titrate the drug too quickly.